everyone. I'm Dr. Theresa Callard-Moore. I am the sexual health specialist here at the Cleveland Clinic, and I'm so happy to be talking to all of you about sexual health after cancer. I apologize. I'm so sorry. This was meant to be an in-person presentation, and I had to be called out of the office. So hopefully I answer a lot of your questions, and at the end, I'm going to leave information of ways that you can reach me if you have any follow-up questions. First, before I talk about sexual health after cancer, I want to cover what is sexual health at all. It is my experience that most people do not have a good understanding about sexual health and pleasure. And I feel like we need to cover this before we can talk about sexual health after cancer. So, the World Association for Sexual Health says sexual health is a state of physical, emotional, and mental social well-being. It's really about our well-being. This is quality of life. It is not the absence of disease, dysfunctions, or infirmities. It requires a positive and respectful approach to sexual relationships and our sexual health, even with ourselves. And it's about having the possibility of pleasure. And I feel like with the medical community, we're focused on disease and we want to help with that. But then we need to look at once that disease is under control, how do we get back to that quality of life? This is where sexual health comes back into play. The first and biggest problem we have is poor sex education. This is really a huge problem because we do not understand how our bodies work, how our partners' bodies work. We don't understand our sexual health, how to give consent, how to communicate about sexual health, how to talk about it when things are not going well. This is such a complicated thing for most people, and it gets us into trouble because if we don't know what normal is, we try to look outside of ourselves going, well, am I normal? Because is this normal? Is that normal? If we get a chance to talk about it with our friends and family, great. But most of the time we do not. Okay. Most of the time that we can't really talk about that freely because we're not supposed to talk about sex. So we look at social media, TV, movies, pornography, if you've looked at that, and say, well, what's happening in the movie? Okay. Right now we see this popular movie, right? Dirty Dancing, one of my favorites. And what do we see in every scene? They kiss each other, they throw each other on the bed, and they start intercourse in about that many minutes. So I'm screaming at the television, going, are you kidding me? She's not ready for that. There's no way. That would hurt to do that. But if we don't know any better and we're looking at those TV movie screens and scenes and saying, I don't want to do that. I have low desire. I am not interested in doing that. That would hurt me. I cannot orgasm like that. It doesn't work for me like that. So we're looking at these scenes in these movies and saying, I don't fit any of that. That doesn't work. I must be not normal. So I feel like it sets us up for a lot of problems. Then we're looking at sexual health in general. My wish for everyone is that sexual health has always been experienced as playful, comforting, or pleasurable. But that's not the case for a lot of people. Some people fantasize about what they think it should be like, but it doesn't match their reality. Some people avoid it or have chosen to be abstinent before marriage or at all. They don't want to be sexually active. Some people are asexual. They think it's gross or disgusting to think about it, do it, or watch it on a show. Some people just want sexual functioning to have a baby. Some people use it as a way to get love and acceptance because they don't know how to have attachment without that. Some people are obsessed about it. They long for it, get over-focused on it. It absolutely is used in abuse of power and coercion from other people. It can be traded for goods or services. If I am low income and I need to get my child to the doctor, I might offer sexual services to someone else so I can get that ride that I need for my family. It is used in exploitation. This would be rape, incest, or molestation, and could be an experience of violence from other people to you. So how people, when I say, I'm a sex therapist, they think, well, she must be trying to get me to have more sex. And if this is your experience and it's a negative one, why would you want to have more of that? Okay, so let me be clear. Sexual health means in a positive way, the way that we described it earlier. The number one complaint is low libido. Low libido is such a huge issue for most people, and they often come to our doctors asking for help about this, but there's not really a pill or a solution that's going to address this because, especially for women, our sexual health and libido is directly related to our environment and our situation and how our body is feeling at the time. So it's like we're a combination lock, and that com is changing every minute of every day. But libido in general has two versions. This is the spontaneous one, and that is this urge or drive we perceive in our brain that says, ooh, I want pleasure. Let's make pleasure. Let's have pleasure today. That's the driver urge. Now, men have that about 75% of the time. Women have it about 15. You may have a flicker of it at the grocery store where it's like, ooh, I might want to play later. And then you get home with those groceries and it's gone. And your partner says, hey, that evening says, hey, let's go into the bedroom. And you're like, no, I'm tired. I don't want to do that. That's normal. Okay. I just want you to know spontaneous desire flickers on and flickers off. So that might not be the go-to thing, but when we don't have it, we think something's wrong. Okay. And our partner does tend to have it. So we're comparing ourselves to our partner and they're saying, well, why don't you want to? I want to all the time. And you're thinking, well, I don't. So what's wrong with my desire? Where did it go? This is my go-to. This is the second form of desire. It's called responsive desire. And it really is a combination of things. If you're feeling emotionally close to your partner, if your environment is calm and safe, which means no kids are going to see you or hear you, the sound machine's on, the door is locked, the kids are asleep, the dog is locked up or has a good toy to play with for half an hour, the cat's not watching you, it's not too late, it's not too dark, it's not too cold, it's not too hot, you're not having a hot flash, and you've shaved recently. That would be a calm environment. And that it does explain a little bit more about that combination lock, because I know all of you are nodding your heads on that one. If you're feeling emotionally close, your environment is calm and safe. And now we have a choice. It's a decision up here, intellectual desire saying, I want to be close to you. I want to do something. And let's be super clear here. I'm suggesting that something is never going to hurt you, okay? Because if it hurts, we're not going to want to do it. But if it's kissing or touching or cuddling or caressing, that feels okay and that I'm willing to do. And sometimes the body can wake up and warm up and say, oh yeah, I want to play. I remember this. I like this person. I want to do this with this person. I want to enjoy myself again. We can have that wake up, warm up happen. And let me just explain. Sometimes it just stays there and it's okay. It's pleasurable. Maybe not orgasmic if you're able to orgasm, but it's just all right. There's another option where your body actually gets turned on. Okay, we're going to talk about that next. That's arousal. And then there's a third option. And this is usually for postmenopause, perimenopause, or medical menopause, which could be part of your treatment. And that is your body says, nope. I don't feel anything. I can't warm up. And this it usually takes about 20 minutes for the body to warm up for women. And your body's not warming up at all. If it's not warming up at all, just communicate that with your partner and maybe transition to something else, which is what we're going to talk about in just a little bit. I do like to include this other model because I think this works well with people who have had some medical procedures done and their pleasure has really been affected by that. And by the way, the medications you might be on. So the first one is capacity for pleasure. Are you capable of pleasure at all? Okay. Second, are you receptive? Now we're back up here. Does that sound like a good idea? And what are we going to do? That depends on if it's a good idea or not. Third, your capacity to respond. This is where sex therapy techniques can come into play. So does your body warm up? Can you get lubrication? Can we add lubrication? Can you get an erection? Can we help with the erection by maybe using a device or a medication? So there's things we can help here, but basically does the body work here? And then the last part is the capability of an orgasm, but not mandated. Sometimes we need to reframe from that. Orgasm is our goalpost to pleasure and connection is our goalpost. So it's not mandated, but it could be possible. Now, arousal is when the body actually does get interested sexually and different things happen. For females, the genitals get swollen and lubricated. The clitoris is going to be more intensely sensitive. And if you're postmenopausal, perimenopausal, or medically menopause, that you might need, in fact, you will need lubrication. I recommend you always have a lubricant on hand. Men, for arousal, this is where they would achieve an erection and be able to sustain that erection. And then orgasm is a very intense thing for some people, and it's very subtle for others, but it is where that threshold of pleasure peaks and tips into the body, and the body relaxes all the muscles, and you have involuntary spasms that happen in the genitals, and you feel a sense of pleasure in the brain. So not everyone orgasms, and again, orgasm's not always the end-all be-all for pleasure. In fact, I encourage all of you to find pleasure in lots of ways, with orgasm being one of the options there. Now, talking to the females, I want you to think about where your disorders might land, because this is a slide that really describes a lot of our patient population. Dyspareunia means pain in the pelvis or pain in the genitals. So let's just start there. If we look at that dyspareunia, it's automatically going to add to low desire, right? If it hurts, you're not going to want to do it. There's no way. And if you're not going to want to do it and you're anticipating it's going to hurt, your arousal ability is going to go down. So your body's not going to respond sexually. And if your body's not responding sexually, you're not going to be able to have an orgasm. And ultimately, vaginismus is one of the words we describe when the vaginal tissue and the muscles inside the vagina tighten up so tight that you could not get a penis, a tampon, a finger, or a speculum in it. So when we're anticipating pain, our muscles clamp up, our whole pelvic floor tightens up. So all of these disorders happen when we have something starting that problem. Okay, so one leads to all the others. And in our case, pain is probably the number one thing we would hear the most about. This is an example of what our patients look like here at the Cleveland Clinic. It really encompasses all of the big picture. So let's start in the top right. Your medical condition is causing pain, or you've had medical trauma, surgeries, procedures, all of the things, radiation, all of that. So now we have a pain response that's very sensitive. Your body, let's go down around the clock. So now we have probably, so this medical menopause or hormone changes or hormone blockers that you're on. So now the body can't do that wake up very easily. It's really hard for it to get warmed up and aroused. And then we go around. Now we have the history of any kind of trauma, accidents, injuries, abuse, sexual assault. A lot of those things put us into fight and flight. So our body then shuts down desire, arousal, and orgasm because the body is saying it's not safe to be aroused and orgasmic right now. And then all the way up, now we're looking at relationship stressors, our caregiver stress, taking care of our families and ourselves. We're feeling overwhelmed and we have low energy. That is the full picture. Those are the patient profiles that we see here in the clinic. And that's just the setup of how things are for probably all of you too, to some degree. All right, so speaking to the men who are watching this video, their male sexual dysfunction is also possible. It can go anywhere from low libido to erectile dysfunction, delayed ejaculation, or a dry ejaculation. If you've had prostate cancer surgery, there's no ejaculate coming out anymore, premature ejaculation, a curvature of the penis called Peyronie's disease, and ultimately all of those lead to some kind of fear or performance anxiety about not being able to be sexually satisfying or being sexually satisfied. So this causes a lot of dynamics too. Really could do that circle thing just like we did for the female patients. I do recommend some resources for you. Come As You Are would talk about just general overall sexual health for yourself. Come Together is also a great resource, and it's about how to engage with your partner even when you have a lowered libido. It's really nice. The way she talks about it is very warm and welcoming and inclusive. So these are my favorite go-to resources. Now let's talk about cancer. When you're going from surviving cancer, okay, now that you have worked through most of your treatment program or you're on a maintenance place, that's when sexual health tends to wake back up and say, oh, okay, where does this fall now? How do we get back to it? What is normal? What is our new normal? Okay, now that we've covered what normal looks like, let's look at your new normal and how to go from surviving to thriving. Surviving includes a lot of complex grief work. It really is looking at everything you've just been through, from diagnosis, mourning those losses, the shock of it all, really the shock of it all, and then the treatment and all the things that you've been through. So, and mourning maybe future losses. It could be, I'm going to miss the feeling that I had when my breasts were stimulated before sexual activity. It could be loss of fertility, the loss of independence because now you have limitations about doing some daily things. It could be anything like that. You might have symptoms of depression. You may have survivor guilt because you were in the lobby with people who didn't have a positive outcome, and you are not sure why things have gone the way you have, and now you're able to move on with your life and other people weren't. Body image issues is probably the number one thing that I hear about, just the changes that you've been through in your body. Your identity. What's your identity? What are you about? What is your role now as a partner, as a parent, as a daughter or a son or a worker or not? All these things. And then medical trauma that you've been through is very real, and the fear of reoccurrence is also real. So if we're moving from those thoughts into some thriving thoughts, and we can kind of blend back and forth. Sometimes we're feeling one and then we go to the other and then we go back. So that's super normal too. But thriving is thoughts about, okay, what is my life? What are my life goals? What am I working towards now? Looking for those short-term goals, like I want to make sure that I get to this appointment today, or excuse me, get back into the habit of driving or exercising. And then seeking help for any mood concerns, maybe going to therapy or couples therapy, family therapy, coping with your feelings better, finding your purpose, maybe changing your purpose. What did you think your life was about? And now what is it about? Maybe just quitting your job and doing something new, something like that. Accepting your body for where it is and practicing self-care and boundaries. Now, your partnership, because a lot of people come into sex therapy and they're really looking for how can I be sexual with someone else? If you're single, we're going to start with your own sexual self. If you're with a partner, looking at how this has affected your partner is where this slide is taking us. Your partner has moved in from caregiver and now is thinking about how do we move back to being lover. And that caregiver it has a lot of feelings too, and maybe we haven't talked about all those yet because we needed to get through everything we needed to get through. But the partner has gone through fear of losing you, trying to fix things. Let me take care of this. Let me do this. Let me do the dishes. I'll pick up the kids. Let me handle things for you because I don't want you to, I just want you to rest, right? This powerlessness feeling like I can't fix it. I can't make you better. There's nothing I can do to fix this. Exhaustion about everything, right? Just simple exhaustion, financial stress, worrying about money and how we're going to cover medical bills, difficulty coping. They're having their own depression, anxiety, stress, substance use disorder, binging on food, pornography, all kinds of things partners do to try to cope with what's going on because of all the things I've already mentioned. So now having that wake up of let me be your lover again, how can we do that? How do I even ask you about that? Right? Remembering that connection, wanting to feel loved, right? Finding common ground as a partner again, being vulnerable in other ways, getting used to touching each other again, and rekindling your desire. This is a gradual process, but when we've been out of the habit of being sexually intimate, it feels like climbing Mount Everest to get back to it. So I think that I'm going to give you some baby steps on ways that you can kind of rekindle things. Um, let's look at your barriers though. These are the more common things that I would hear. Low desire, we covered already. Fatigue, 100% fatigue. If you don't have the energy to do anything, you're really not going to have the energy to be sexual either. You might feel nauseous. You might have vomiting, depends on your medications and treatment. You might still have pain. You might have overall pain, just walking, standing, sitting, but you might specifically have pain with sex, especially if we have hormone blocking agents in place and you have atrophy in the vagina. You might not be able to tolerate any kind of penetration with a finger, mouth, or toy or a penis. So that may cause some barriers. Hot flashes, weight gain, which gets into body image issues, mood changes, surgery scars. You're kind of uncertain about how's your partner going to feel looking at you with a scar or an ostomy bag. Leaking urine or fecal matter. You might not be able to have control over that right now, or might need to wear some Depends or some products to catch urine. And all of these things make us feel not so sexy. So once I hear what those breaks are, I call these breaks or barriers. Once I hear what the break is, then I get really creative. How can we work around this? How can we or work around it? Either avoid it altogether, work around it, or overcome it. Okay. So let's talk about that. So accelerators and brakes is what I'm talking about now. This does come from that book, Come As You Are. Accelerators are, yeah, that sounds good. Okay, like what do you want for lunch today? Oh, that sounds good is kind of what I'm talking about. And then if there's brakes, it could just be a subtle break like, no, that doesn't sound good right now, but maybe tomorrow that would sound good. Or a heavy break, that doesn't sound good and I don't want to do that tomorrow either. I like this model. The tipping point is really a nice way to see is something really kind of lighting me up and exciting me, or is this cooling me down and putting on a break? Okay, so this next slide is a little bit difficult to read, but it goes into how nuanced these things can be. What are my thoughts right now? What am I feeling right now? Am I under the influence of any kind of medications right now or alcohol right now? How are we getting along? Because how you treated me in the kitchen this morning over coffee is directly related to how receptive I'm going to be to you in the bedroom tonight. Okay, what is the sexual script that we're playing out? Is that sexual script going to cause some pain for me? All of these it's very subtle, but it's complex, and it tips that scale, as that last slide showed us, that, oh, that's cooling me off. Okay, wait, that's warming me up. Oh, that's cooling me off. Wait, now that's warming me up. What can I do to warm me up a little bit more? That would be the idea that I want you to think about with those brakes and accelerators. So the idea of getting in touch again and being physically intimate again on any level is really a calculated vulnerability. What is okay for me right now? And this is a map I want you to think about. Let's just start subtly and work into it. So basic pleasure, let's start there. What brings you pleasure just day in and day out? It could be a bite of food. It could be breathing this fresh air. It could be the sun shining in the window. It could be the sound of kids laughing. Relaxing with your good book. Someone holding your hand. Getting the dishes done. Oh my gosh, that definitely helps me feel better. Moving your body a little bit, exercising, being productive at work, getting back to the grind again and getting back in your groove and feeling good about being productive. What brings you some pleasure? Focus on that, right? Build on it. Let's connect it. Let's connect these things together. So now we're feeling in a pleasurable place most of the time. With your partner, start between your ears. Thinking about things in a pleasurable way, thinking about sexy things, maybe that you used to do together or with yourself. Okay. So thinking about those pleasurable things and get your mind in the game. Okay, and then let's see if your body can catch up. I like the phrase "I'm on my way to" because that allows us to develop a positive way of thinking. This is borrowed from cognitive behavioral therapy, if you've done any of that. So cognitive behavioral therapy is just reframing the way that you think, and that affects how you feel and what you do. So if we say, "I'm on my way to taking care of my body. I'm on my way to receiving compliments better. I'm on my way to finding joy. I'm on my way to find pleasure." If you add something like this, now the brain takes that sentence and runs with it, and then everything you do is like, "Oh yeah, that's you finding joy," or "Oh yeah, that's you finding pleasure." "Oh yeah, that's you feeling better about your body." So we're feeding on it. Once we start the right sentence, it allows our brain to start working around that. You may be doing physical therapy already. That could be helpful. I go over with a lot of patients how to use dilators at home. So there's things that we can do to work on those areas that might be off limits right now because it hurts. But you might be able to move your body in certain ways and start to introduce some pleasure. Then you can figure out what feels neutral, which is no pain, or if it starts to feel good, say, hey, it actually feels good. Like if, let's say post mastectomy, it hurt to do a hug. Well, it does feel good for you to hug me from behind. Let's do that. That feels good. So if you find something that works, tell your partner about it, and then you can build on it from there. This is my favorite way to map these things out. Take a couple pieces of paper. Green lights, yellow lights, red lights. Green lights would be, yeah, that sounds good. And there's usually never a break that shows up. It could be holding hands, going for a walk, cuddling, watching TV together, things you would do with other loved ones, like your own children, not just a partner. And if you're dating, these are things you're going to do automatically. And then yellow lights, we're going to come back to that. Let me go to red first. Red is heavy break, no interests. So this is something that's gross, painful, yucky, immoral, bad. Someone can see you and hear you, and that's not okay. Anything that would shut things down for you. We might need to put something like intercourse over here or some penetration with fingers or toys even because things hurt right now if you're female, or if you're male and you can't get an erection, we might just take erection off the menu. Let's not worry about that right now, okay? Now, what can we do with this? Because here's one piece I need to say. A lot of our patients say, well, it does hurt, but I'm trying to do it anyway. If you're doing something and it's painful, you might be thinking yes and saying yes, but your body is saying no, no, stop. And if your body is doing that, you're programming the body to respond to the pain and you're connecting it with sexual activity and your partner. So I recommend if it hurts, let's set it aside and work on it with the medical team. But come back to yellow. Yellow is what can we do that's pleasurable, intimate, fun, and doesn't hurt, and can lead to orgasm if we mix and match. So the first several things, I suggest being very sensual things like taking a shower together, or maybe giving a full body massage, or using our hands and just tickling the body and touching the body back, front and back. And now we can add to it. Let's do that with a feather. Let's do that with an ice cube. Let's do that with something silky. And what we're doing is we're looking for the 7 to 13 erogenous zones in our body that gives us really a great pleasurable feeling. Not necessarily orgasmic, but just feels good. And some area might feel better with an ice cube. Some area might feel better with a feather. But really learning to get used to touching your partner again. This is a nice exercise to do for a few months even, and just get used to it again. Then you can add to it. Can we do outer course? Which if it's a partner who has a penis, you can put lubricant between the thighs, between the buttocks. You can rub the penis on the belly. Anywhere that you can get friction with some lubrication could be pleasurable for that partner and even orgasmic. You could add tie-ups. You could add toys of all kinds of toys. You could do role plays. You could read erotica, write erotica, watch erotica, and get your head more in the game of something that's interesting to you sexually. You could bring out the chocolate syrup and then lick that off and then go take that shower. So we can open up the recipe book and none of it hurts, and it does feel fun and pleasurable and gets those accelerators going. That's the idea of green, yellow, red. So what this does is it facilitates conversations with your partner and ways to find and create intimacy again, and especially when without pain. Now, sex therapy can add specific suggestions on top of that. So there might be different moisturizers or lubricants that we can go over. We can maybe try lingerie. If your break is one of those things that says, I just had a mastectomy and I feel uncomfortable about not wearing a shirt in front of my partner right now. Okay, let's get some lingerie and use your prosthetic in that lingerie if you want, or just wear the lingerie. And now you can have a sexy time without worrying about what your partner is thinking or feeling or how you're feeling about your body. That would be an example. And then, of course, I can go over dilators and things that would help with relieving some of that pain that we talked about earlier. Sex therapy also includes intensive therapy that you would get in a typical couples counseling or individual counseling. excuse me. Cognitive therapy is one of the basic ones. There's other forms of that, internal family systems. I talk about EMDR, ways to recover from trauma. So there's different things that sex therapy offers, but we might want to look at, what do you really need? Do you need long-term therapy? Do you need long-term sex therapy? Do you need couples counseling, family counseling? So this is just a way to encompass all of those needs as they come. I do really like this resource. Intimacy After Cancer is a great read. The whole time I was reading it, I'm like, oh, I would have wrote this book too. This is exactly how I would say it to a patient. So this is one of my favorite books when you're looking for something to just, how do we get back to these things? So I like this one because it is specifically about post-cancer. And I want you to know about our shared medical appointments. This is under the Women's Comprehensive Health and Research Program here at the Cleveland Clinic. We have shared medical appointments where you can join in and ask questions, because a lot of the post-cancer treatment does put you in a menopausal state if you're female. And these are great questions you can ask and look at all of your options for treatment if you're not able to do hormone replacement therapy or localized hormone replacement therapy. So I just want you to know about this resource, and the same number to reach me is the same number to reach these shared medical appointments. And our sexual health providers, we have sexual health doctors who specialize in helping patients recover and get back to their sexual health needs. So I appreciate the time to talk with all of you. This is the number to reach me, and my email is there as well. If you have any questions, feel free to email me, and I can even call you and answer those questions if you would like. But you can also call and set up a sex therapy appointment by using this number, 216-444-8686. Thank you so much, and I hope this was helpful, just going over what is normal and then how to recreate your normal. And I appreciate the time. Again, my name is Theresa Callard-Moore. I'm the sexual health specialist here at the Cleveland Clinic. Thank you.